gynecological pathology here at Stanford. And he finished his AP and CP training at Yale School of Medicine and is currently a GynPath Fellow at Stanford. I have not had the opportunity to meet or engage with you because I think we move in slightly different circles. GynPath has never been my strength. So I have a lot of respect for people who can make sense of this complex gyn specimens. Before his AP and CP training, he did his medical school at Loyola University, and before that, he did his bachelor's degree from University of Michigan. And he has been a member of the resident council at ASCP for the last 4 years, has a lot of gyn publications, and I'm delighted that you're interested in this position and looking forward to your talk. Thank you. And please type in your questions or speak after the talk, and Casey will be monitoring the questions. Thank you.
Good morning. Thank you all for attending. As mentioned, my name is Austin McHenry. I'm a GYN pathology fellow here. So I want to thank you all for giving me the opportunity to discuss some of the work that's been going on in this department for a while now, long before I got here, on the pathologists, particularly the gynecologic pathologists' role in screening for hereditary leiomyomatosis and renal cell carcinoma syndrome. I have nothing to disclose. So I'm going to briefly define clinical features, pathogenesis, associated tumors of HLRCC. We'll discuss current practice in the gynecologic pathologists and the GYN pathologists' approach to smooth muscle neoplasms or mesenchymal neoplasms of the uterus. We'll review some current opinion on who should be screened for HLRCC in that context. And finally, I will share some recent data that hopefully addresses some of the gaps in our understanding of this syndrome that may better stratify women with leiomyomas for HLRCC screening. So while there had been many reports of cutaneous leiomyomatosis seeming to run in families, it wasn't until 1973 that Reed published this first observance of cutaneous and uterine leiomyomas that occurred in two families of successive generations. So he concluded that this inheritance pattern was autosomal dominant. And at that time, Reed syndrome was coined. But it wasn't actually until about 20 years ago that this inherited susceptibility was mapped to a gene in chromosome 1, at which time mounting evidence supported an additional association with renal cell carcinoma. And then it took us another 15 to 20 years to decide that tumors associated with this gene should be recognized as distinct entities in both the genitourinary and gynecologic WHO classifications of tumors. So it's now established that HLRCC syndrome is caused by germline pathogenic variants in the FH gene. More than 100 different pathogenic FH variants and large-scale deletions have been reported. So this figure isn't meant to be legible. It's just to give you an idea of how many alterations have been identified within just a single study in France of 114 families with HLRCC. So I think in here there's 68 distinct germline mutations identified. So most are missense, then truncating or frame shift, then splice site, and then large deletions. And so like many tumor predisposition syndromes, HLRCC, it's autosomal dominantly inherited. So patients with HLRCC, they'll inherit a mutated copy and a wild type copy. So what actually happens if you inherit 2 mutant copies or you don't have any copies? So that disease is actually called FH deficiency. And that would present with severe neonatal and early infantile encephalopathy. Most die in early childhood, if not before birth. But in HLRCC, tumors acquire loss of heterozygosity, a second hit. So that then leads to a decrease or loss of function. So there's no genotype-phenotype association. with this disease, meaning your genotype doesn't predict the penetrance of the disease or whether or not you're more likely to get a certain tumor versus another tumor at a certain age. But there's one caveat to that, which I'll discuss. So now the excitement begins. We're going to talk about the Krebs cycle. So please, everyone, have a seat. The folks on Zoom, make sure there aren't any young trainees next to you that are hyperventilating. We don't want any casualties in this talk. So fumarate hydratase, it's an enzyme in the Krebs cycle or citric acid cycle, which this occurs in the mitochondria. So the cycle takes in acetyl-CoA from carbs, fats, proteins, and then it spits out products of oxidation, CO2, some energy, and some reducing agents for some other metabolic pathways. And what's shown here, this cycle makes it look like every single step is necessary, but that's not actually how this works. There's actually a lot of other additional pathways that allow this to work when one enzyme doesn't work, that we've recognized now in the last 20 years. But when it works, FH, it normally converts fumarate to L-malate. And this occurs in the mitochondria, as mentioned. So an absence of FH, say from biallelic inactivation, that results in accumulation of fumarate. And so this then leaks out of the mitochondria and into the cytoplasm. And why is that bad? Well, it turns out that high fumarate will interfere with normal activity of a hypoxia-inducible factor pathway. So HIF1, it's a transcription factor that responds to low oxygen. So it tries to help cells get cells and tissues respond in a way to mitigate hypoxia. So you don't want this constitutively activated. And how does this work? Well, increased cytoplasmic fumarate results in competitive inhibition of PHD. PHD, it's very smart, it has a PhD, it stands for HIF prolyl hydroxylase. So inhibited PHD leads to decreased degradation of HIF1. So it hydroxylates HIF1 in normoxic conditions with iron and alpha-ketoglutarate around. So VHL, which isn't shown here, also forms a complex with hydroxylated HIF1 and it ubiquitinates it, causing degradation. So in hypoxic conditions, PHD doesn't hydroxylate HIF1 alpha. HIF1 alpha is then able to upregulate several genes for growth. Platelet-derived growth factor results in autocrine growth stimulation. VEGF promotes vessel growth. GLUT1 increases intracellular glucose. And eventually, subsequent accumulation of other oncometabolites leads to neoplasia through epigenetic modifications and suppression of DNA repair in HLRCC tumors. Whew, we made it through that. So this syndrome is rare, but there's actually no data on its exact prevalence. Nonetheless, more than 300 families have been reported to date, and the estimated population incidence of pathogenic germline FH variants is about 0.035. So that's like 35 people in 100,000. So it's rare. And overall, the disease phenotype is highly penetrant. So the literature will tell you that almost all patients with HLRCC will develop cutaneous leiomyomas, and almost all women will develop uterine leiomyomas. I'm going to show you some data that say that this number, especially for cutaneous leiomyomas, might be a little inflated. However, only about 15 to 25% of patients will develop an associated renal cell carcinoma. The development of pheochromocytomas is exceptionally rare, and actually there's some new data that says it might be one of the only genotype-phenotype associations in HLRCC, meaning specific germline FH variants can cause malignant pheochromocytomas and paragangliomas without other manifestations. So in 2016, the GU WHO defined a new entity. How and why did this happen? Well, actually, it was the recognition of a unique histology that was integral to identifying the syndrome. So by definition, these tumors have biallelic inactivation of FH. These tumors are really aggressive. these are not the kind of tumors that you want to manage with active surveillance. They're often solitary, they're often unilateral, which is relatively unique for syndrome-associated renal cell cancer. And they have variable gross appearances. So in Dr. Lau and Chan's recent evaluations here of 32 patients with FH deficient RCCs, 71% presented with stage PT3 disease or higher. So 16 of 34, that's 50%, had metastasis at presentation. And 13 of those 32 patients, about 40%, had subsequent metastasis. So together, that's like 24 out of these 32 patients, or about 75% of cases that presented with eventual metastatic disease. And of the 26 patients in the same study with follow-up data, 50% died of disease at the end of follow-up. And so the median survival, the median follow-up here is 16 months. So like only 8 were alive with disease, only about 30% were alive with disease, and less than 20% showed no evidence of disease at the end of follow-up. So together, that's a lot. So these are really awful tumors, really awful tumors. So once a family member is diagnosed, immediate relatives should be tested. Long-term follow-up surveillance imaging is the most important aspect of HLRCC management, since the lifetime renal cell cancer risk for FH variant carriers is about 15 to 20%. The risk of RCC between ages of 10 and 20 years old is actually not negligible. It's about 1 to 2% and continues to increase throughout adulthood. So contrast MRI through the kidneys is recommended every, depending where you are, depending what you read, between every 6 and 12 months. Ultrasound is not going to detect these small tumors, and it's not recommended. So then the idea is prompt surgical intervention with wide surgical margins and consideration for retroperitoneal lymph node dissection are recommended even for small tumors. And so frequent screening is recommended to detect even very small tumors for which early surgical intervention can decrease the potential for metastatic disease. So what do these tumors look like? FH deficient RCCs, they typically demonstrate multiple admixed morphologic patterns. So that is most often like 2 or more patterns in the same tumor. So in the past, many of these cases were described as unclassified high-grade renal cell carcinoma, or unclassified with predominantly X pattern, tubulocystic carcinoma with some dedifferentiated component. And often they were just called type 2 papillary carcinomas. So the most common pattern is papillary, shown here. So we see papillae that are often like hyalinized, and they don't usually have foam cells. And importantly, eosinophilic macronucleoli is a common feature, but it's not specific. So cells, they often show perinucleolar halos, and some call these eosinophilic macronucleoli viral inclusion-like. Tumors are commonly solid. You can see how this could be mistaken for a number of, your differential could be quite large. You could think of a collecting duct carcinoma. Tumors can show cribriform sieve-like patterns. You could appreciate that this could resemble an acquired cystic disease-associated RCC. And rarely, tumors can show tubular or cystic growth. And other patterns would include collecting duct-like patterns, urothelial carcinoma-like with nested growth and desmoplasia, and a variety of low-grade oncocytic types. So negative immunohistochemical staining for fumarate hydratase in tumor cells in the presence of background positive FH staining in internal non-neoplastic cells is highly specific for FH deficient RCC, but its sensitivity comes into question. So why might it not be sensitive? Well, if your pathogenic FH alteration was a deletion or a truncating mutation, that would obviously not stain with an antibody against FH, you'd see loss. But what if the alteration causes loss of function in the protein rather than loss of expression, say in the form of a missense mutation? Then theoretically, your amino acid, if your amino acid sequence was of a similar configuration, you could still see FH staining, and you wouldn't have loss. So the most recent studies show that FHIC loss in RCCs is about 84.7% sensitive, but near 100% specific. Dr. Lau's paper that just looked at FH mutated tumors showed similar sensitivity. So it's not a perfect screening test, but it is pretty good. In contrast, aberrant staining for a marker called 2SC, it's thought to be highly sensitive for FH deficient RCCs, but perhaps less specific. So abnormal here is positive accumulation of 2SC. Normal cells should not have any 2SC staining. But what exactly is 2SC? It is S2-succinylcysteine. It's not some ubiquitous metabolite, but rather it's a chemical byproduct of fumarate accumulation. So we're back in the Krebs cycle. Accumulation of fumarate protein, it spurs this spontaneous reaction with cysteine sulfhydryl groups on any accessible protein. So this whole phenomenon is called protein succination. So it's literally just fumarate getting stuck onto cysteine at the sulfur molecule and at the second carbon molecule of fumarate, which actually, if you look at the cycle, it's just succinate. It's just fumarate is just succinate with a different amount of protons. It got reduced if we go backwards in the cycle. So theoretically, even if you have a non-functional fumarate hydratase enzyme being expressed, 2SC will be made. Cool, huh? So Chen et al. Looked at how useful this stain is in this setting, and all of their tumors with FH mutations had aberrant 2SC staining. However, 5 of 14 tumors without FH mutations showed 2SC aberrant staining. So this corresponds to 100% sensitivity and about 64% specificity. So that specificity is kind of, it's not great, right? But actually, some more recent publications, this interinstitutional study said, well, wait a minute, how much staining actually is positive? If you look on the left, you can see that some of those unclassified RCCs, their 2SC staining intensities, like some of them is 3+, but some is 2+, some is 1+. So what exactly does this mean? So this second paper, they determined that if you rigorously define what positive is, then the specificity is a little bit better. So an IHC product score is calculated out of 300. So you just essentially multiply the percentage of positive tumor cells, that's PP here, for each stain intensity. So strong is 3, moderate 2, weak 1, none 0. And then you add them up in each tumor cell or in each tumor using this formula. And if that score is over 90, they determine that that's positive. And overall, using that, 2SC is exceptionally sensitive and more specific, up to 91% specific. So 2SC, very sensitive, but not as specific. FH, very specific, but not as sensitive. Do all FH deficient renal cell carcinomas have germline alterations? Is the presence of this tumor diagnostic for HLRCC? So each of these 3 investigations had 9 patients, interestingly enough, who underwent germline mutational analysis for fumarate hydratase. In all of these, only 1 patient was found to have somatic, but not a germline FH alteration. So the answer is almost always yes, all tumors should be assumed to occur in patients with germline FH mutations or patients with HLRCC. But in exceptionally rare instances, tumors can not read the books. Tumors can just develop a biallelic somatic loss of fumarate hydratase. So what happens in the skin? The literature will show pictures like this with like tumor-like exophytic cutaneous nodules within a plaque of like and then there's background like confluent smaller nodules. And it seems that the trunk and the upper extremities are more affected, but the lower extremities are also common sites. But many cutaneous tumors are actually clinically much more subtle. So it can be like non-exophytic, just this pink banal appearance. And then many are actually even more subtle. So if you saw something like this on your chest, would you think that much of it? I think, we probably would, but I think a lot of people might just think it's the product of aging, wouldn't really bring it up to their doctor. Or if it doesn't get much bigger, they might ignore it. HLRCC-associated cutaneous leiomyomas are mostly piloleiomyomas. So for reference, I'm showing you an example of a non-FH deficient pilar leiomyoma. They arise from the erector pili of the hair follicle, and they are painful. They're part of the blend and egg mnemonic for painful skin tumors. This is the L. And so people get this intense shooting pain that's aching sometimes, and it's sensitive to pressure. And then they also present with what's called a pseudoderrier sign, which is this transient piloerection of the nodule after rubbing. So you rub it and then it stays elevated. But in this histology, what we see here is sort of displacement of the dermal appendage with a haphazard arrangement of smooth muscle fascicles dissecting between some collagen. Nuclei are really bland, they have blunt ends. But in FH deficient tumors, the tumor is much more cellular, shown on the right. And there's abundant fibrillary collagen. There's focal atypia, perinuclear clearing with enlarged eosinophilic nucleoli are seen. And also we see cytoplasmic eosinophilic globules. Mitosis should be rare. So complete loss of fumarate hydratase expression in the tumor cells with retained internal controls is also seen. So loss of fumarate hydratase expression and enhanced expression of 2SC is similar as in renal tumors. But how do these stains, what does the data say about them in the skin? Well, staining of cutaneous leiomyomas, it's typically not standard practice in this setting. Usually, like I think only a history of like multiple leiomyomas, if that were given, when you would really stain this for 2SC, I think in most practices, if you had some morphologic atypia. So in one small study, 2SC stained all 11 FH mutated tumors, but 2 non-FH mutated tumors as well. So sensitive, but not specific here. Whereas FH loss occurred in only 6 of 11 FH mutated tumors and 2 of 2 tumors without FH mutations. So this study said it was neither sensitive nor specific. But subsequent evaluations have shown that FH has excellent specificity, but lower sensitivity. What about FH leiomyomas in the uterus? Well, it was only 2020, a GYN who included this as a distinct subtype of leiomyomas. So they're reported to be large, symptomatic, and present at younger ages than their non-FH deficient counterparts. They have characteristic morphology. So that's supposed to include hemangiopericytomatous vessels, oval nuclei with prominent eosinophilic macronucleoli, a perinucleolar halo, eosinophilic cytoplasmic inclusions, sometimes schwannoma-like growth, and a chain-like distribution of tumor cells. So this is what it looks like. At low power, you instantly see some bizarre nuclei, which we might say are packeting together. And so all these images I'm going to show you now from Dr. Longeger, you might recognize these images are of FH germline mutated tumors. And at higher power, we see that some large nuclei of varying shapes and sizes. The cytoplasm is very eosinophilic. It's very granular. Even in other areas, we see these eosinophilic cytoplasmic inclusions. It can be somewhat rhabdoid. And they often have hemangiopericytoma-like vessels. So the lumen's often larger than the thickness of the vessel would otherwise indicate it should be. But note, note this beautiful cherry red nucleoli here with a perinuclear halo. But this finding is not specific. You can, of course, see this in many tumors. And here, note there's granular cytoplasm again, and it looks, in this instance, it looks more flocculent. And sometimes this particular tumor can sometimes resemble a pecoma. So here's another picture of really granular flocculent cytoplasm, eosinophilic nucleoli. In other tumors, the nucleoli are not eosinophilic, they're blue. But the cytoplasm, in our experience, seems to be the best clue with this granular, abundant, somewhat globular appearance. And the nuclei are more round. So tumor cells will lose FH, fibroblasts in the black background retain FH, 2SC is accumulated in the cytoplasm and the nucleus. So can FH deficient uterine leiomyomas be somatic? Well, one of the first studies to publish this, not long ago, actually, by Harrison et al., noted that 1% of unselected uterine leiomyomas have FH-IHC loss. And they did not show any leiomyosarcomas with FH loss. So the answer is absolutely yes. FH deficiency in leiomyomas does not mean that you have HLRCC. And large studies of the genomic landscape of uterine leiomyomas has shown this as well. So the vast majority of leiomyomas of the uterus have MED12 alterations, but yes, 1% can have FH somatic mutations. Can these tumors metastasize? So the phenomenon of benign metastasizing leiomyomas, it's not unique to non-FH deficient leiomyomas of the uterus. So it's important to recognize that tumor recurrence in the pelvis is possible if surgical manipulation allows for it in any kind of leiomyoma. And similarly, the phenomenon of intravascular leiomyomatosis can occur in benign smooth muscle tumors of the uterus without any underlying histologic clues to explain this behavior. So this is a patient of ours who has a germline FH mutation, had a prior FH deficient leiomyoma resected, who presented with a lung met of this tumor. So it can happen. And it didn't show any features of malignancy. So do the somatic tumors in the uterus look any different than the ones with germline FH deficiency or germline FH mutations? Well, Mittinen describes what he thinks is a non-germline morphology. So generally, these tumors that are so his hypothesis is that generally they're less atypical, they're more oval, they have like less or no cellular packeting, they have chain-like palisading nuclei, they may have more prominent staghorn vasculature, their eosinophilic nucleoli are much smaller, and they probably have a lower mitotic rate. So in this example, you see they're immediately not as atypical. This is not so much packeting as the other tumors I showed you. The nucleoli are smaller. It really just looks like a typical leiomyoma. I don't know that anyone would be suspicious of this tumor. But at higher power, if you look closely, you still see the features shown earlier, but much less pronounced. There's still prominent eosinophilic cytoplasm. There's still some rounding of the nuclei, still some nucleoli. And then here's another view showing again the nuclei are less round, but nucleoli are still seen, much less prominent. Again, in the uterus, just because you have an FH deficient tumor or one that shows accumulation of 2SC does not mean that you have a germline FH mutation. So what does the data tell us about the utility of FH and 2SC in the uterus? So like the kidney, FH seems exceptionally specific for FH deficiency, but also suffers in its sensitivity. But 2SC is really not well studied yet. Does FH deficiency preclude malignancy in uterine smooth muscle tumors? We tend to sort of assume that it does. Whenever we find one, we think, oh, we put a name to this tumor. That means it's not a leiomyosarcoma. But actually, there have, and in the olden days, there have been a lot of reports claiming that some of these tumors can behave in malignant fashions. And I think, at least I was always wondering, oh, were these actually leiomyosarcomas, misdiagnosed based on morphologic criteria alone? However, this very recent study published this year says that about 1 to 1.5% of uterine leiomyosarcomas are FH deficient. And some of those do have germline mutations. So you can't hang your hat on FH deficiency as being benign. You have to put all the pieces together. You have to look at other histologic factors that should play a role in deciding if something is benign or malignant. But that really brings us to a very important point in uterine mesenchymal neoplasms. The criteria to determine malignant behavior, it actually differs between certain tumors. So we should really be keen to getting the right diagnosis and expanding our differential in some of these unusual tumors. But the problem is that many malignant entities can have deceptively bland morphology. And similarly, many atypical findings in benign entities mimic malignant features. So, and what's interesting in GYN pathology is that a lot of the specimens you receive in daily practice, they're definitely not all treated the same. So some are just sampled hysteroscopic myomectomies. Some are abdominal myomectomies in which there's in vivo fragmentation of the tumor. Sometimes the full resection gets morcellated. So it's really hard to determine, it's really hard to evaluate borders and to know if what you have received is actually representative of the tumor. So let's explore the differential. So in this tumor on low power, we see a neoplasm with vessels that are thin-walled and staghorn. But what's going on with these nucleoli? Nuclei. Higher magnification shows you these crazy looking nuclei. Even some cytoplasmic eosinophilic inclusions are seen. There's some nucleoli, they're not very prominent. These nuclei are even more strange. They have massive eosinophilic nuclear inclusions. They get really wild. And does anyone see a mitotic figure here? No, I wouldn't categorize any of these as mitotic figures, but counting true mitotic figures can be really challenging in something like this. And then the same question, is that a mitotic figure? I think no, I think it's just an explosion of chromatin. So when counting mitotic figures, you want to see like unequivocal karyokinesis. So what is this tumor that has a lot of the same histologic or morphologic features of FH deficient tumors? This is a leiomyoma with bizarre nuclei. And so importantly, they shouldn't have any tumor cell necrosis. They should not have mitotic counts greater than 10 per 10 high-powered field. And usually they're much less than that. They're like usually less than 5. And they only have diffuse or focal severe atypia. And so back in the olden days, many of these were just called leiomyosarcomas. How could you not call this malignant? The problem is if you follow them up for a long time, like Dr. Longacre did, these patients, they keep living without any recurrence. So I think in her study, she had a mean follow-up of 6 years. Others, at least in her study, only like 2.6% had local recurrent disease, which again, I've said can happen in any smooth muscle tumor that is incompletely excised, that's benign. And then others reported 0 recurrences. So if this were really a leiomyosarcoma, this tumor would probably metastasize to the lung within 2 or 3 years. So actually, I'll go back. Something that's unique to this tumor is that it probably interfered because people might have called these leiomyosarcomas. It probably diluted the survival characteristics of true leiomyosarcomas. So, we're now trying to really only look at newer data to look at survival characteristics of leiomyosarcomas in the uterus because they're bad. And I have another tumor here. It looks like it could be epithelioid. Could it be an epithelioid smooth muscle tumor? Sort of has some rhabdoid features. It has some granular cytoplasm. It looks a little spindle too. You might think of a rhabdomyosarcoma. You might think of an FH deficient leiomyoma. A different section shows some increased eosinophilic cytoplasm, similar to FH deficient leiomyomas. But this actually has a subtle different look to the cytoplasm. This looks very, now that I think about it, looks very similar to a tumor Xiaoming had just a few weeks ago. So, and the characteristic word I'm looking for here is web-like. So this web-like appearance of the cytoplasm. And of course, there is nuclear atypia. Another area here might show very round nuclei, prominent nucleoli, but no perinuclear halos. So definitely could be an epithelioid smooth muscle tumor. The cytoplasm is really granular here. So thoughts on a differential? Well, if I show you the next slide, if you throw in an HMB45, it's very positive. So could this be a PEComa? Yeah, it's a PEComa. So these are fascinating tumors that can mimic plenty of other tumors in the GYN tract. Generally, they don't express desmin or caldesmin, but they can focally. And often they express a little bit of SMA. And of course, they express HMB45. So the hallmark of these tumors is that they express muscle and melanocyte markers. So they can express melon A, MITF. They really shouldn't express S100. They can focally, but we're never thinking about missing a melanoma here. But their morphology is characterized with this spindle to epithelioid cells in short fascicles or nests. They have similar intricate vasculature, granular cytoplasm. And interestingly, if you start staining every mesenchymal uterine tumor with HMB45, you'll see that HMB45 can be expressed in a lot of entities that definitely don't meet criteria for PEComa, to be a true PEComa. And this really can be a problem. So you can see it in normal myometrium, you can see it in run-of-the-mill leiomyomas, you can see it in high-grade leiomyosarcomas, undifferentiated sarcomas. So you really should hold out on histologic, morphologic findings that suggest a PEComa most of the time. So if HMB45 isn't really specific for this entity in the uterus, are PEComas of the uterus a real entity? Are they different from other tumors? Do they just represent a spectrum of differentiation that can happen in any other mesenchymal tumors? And I think actually most, at least here, maybe most GYN pathologists think that like both can be true. You can have tumors that are molecularly classic picomas that have associations with lymphangioliomyomatosis and tuberous sclerosis. And then you can also have tumors that are probably just smooth muscle tumors that just happen to express picoma markers. So you have to be careful. So like I said, not all criteria for malignancy is the same in the uterus. So it's suggested that if your tumor has 3 or 4 or more of these features, may behave in a malignant fashion. So it's big tumors, high-grade atypia, more than 1 mitosis per 50 high-powered field. This is a much lower threshold than leiomyosarcoma, and necrosis and LBI. So back to HLRCC. Thankfully, we see that the more penetrant tumors in HLRCC seem to occur at younger ages. So can you imagine if this were the other way around? That would be much worse. So skin tumors around 30 happen around age 30. Leiomyomas happen around, uterine leiomyomas happen around 20 to 30 years. And FH deficient renal cell carcinomas tend to happen 20 years later, around mean age of 46. So in theory, if you can identify these patients early, you can set them up for screening and prevent the development of high-stage renal cell carcinomas. But how many FH deficient tumors of these histotypes in anatomic sites actually have germline mutations? Well, as shown here, the vast majority of patients with multiple cutaneous leiomyomas, not necessarily like one FH deficient leiomyoma, they do have germline FH alterations. Similarly, even a single FH deficient renal cell carcinoma presenting at any age is very, very likely to have an identifiable germline variant. But in contrast, only 2 to 4% of patients with a single FH deficient uterine leiomyoma will carry germline FH variants. And only 1% of patients with pheochromocytomas and paragangliomas will have germline FH variants. So there's some clinical guidelines for suspecting HLRCC for genetic counseling, triggering genetic counseling. Interestingly, here it says nothing about FH deficient uterine leiomyomas, only severely symptomatic before 40 in the uterus. So, these criteria for clinical suspicion were written a long time ago, but this is what, clinicians are looking at and up to date. And then similarly, confirming diagnosis, they were, before germline testing was widely available, there were some other criteria, but now everyone should really get pathogenic germline FH testing. So the question remains, who should get screened? And what role does the anatomic pathologist play? And the problem is that leiomyomas are really common, and HLRCC is really rare. Similarly, FH deficient leiomyomas are way more penetrant than FH deficient renal cell carcinoma. So is the risk high enough to live your life with constant cancer screening? And FH and 2SC, they're not specific for germline mutations in uterine leiomyomas. So could we just be overutilizing these tests? And lastly, why don't we just leave this whole problem up to dermatologists? Isn't it easier to find, to identify multiple leiomyomas, cutaneous leiomyomas than uterine leiomyomas if they present earlier? Well, I can address 2 of these problems. Some inter-observer studies actually showed that proposed morphologic criteria for FH deficient uterine leiomyoma, so morphologic criteria, is not reproducible. Secondly, in Dr. Lau and Chan's recent study that was of 32 FH deficient RCCs, only 10% of patients, this is everyone with, germline variants, only 10% presented with a history of cutaneous leiomyomas. We're told that this should be like 90%. So why is this? Is it poor clinical history taking, poor physical exam? Do people not, do they just live with these? Is it something to do with inclusion criteria for identifying study populations? We don't really know. So that's really what has sparked our interest in actually screening in the uterus. So in the last 3 years, there's been a few published opinions on this matter. Most actually, despite what I just told you, most suggest that FH deficient tumors of the uterus can be identified based on morphology alone. There are single institution studies of, GYN pathologists describing these. So, our neighbors, they note that relying on abnormal FH immunostain alone to trigger genetic counseling referral would miss 2 of 5. So that's 40% of cases with a pathogenic FH germline mutation. So that's using FH only. Well, we have been collecting data of our own. And we wanted to know, what is the role of age at presentation? What that role actually is if we were to do this prospectively. And also, the data on 2SC in the uterus is still lacking. So we did a simple prospective study over a few years. So with the idea that many women with HLRCC develop symptomatic uterine leiomyomas 10 to 15 years earlier than potential RCC. So since it's suggested that morphology and FHC and 2SC IHC can be helpful for screening, but data is limited to small series and nothing's prospective. So in May of 2019, we started staining FH and eventually 2SC on all uterine leiomyomas, regardless of morphology in patients less than 40 years old. We later modified this to 30 in 2022. And we suggested genetic counseling if these stains were abnormal in the tumor. And then we correlated with germline FH testing when that was available. So we collected 702 leiomyomas that were screened. So of these, all of them exhibited at least one feature of FH deficient morphology on retrospective review. So this is my retrospective review. And so having at least one or more of the following, would be staghorn vessels, bizarre nuclei, cytoplasmic inclusions, perinucleolar halos. But really, this might be incredibly too loose of a definition, so it doesn't describe the difference that Mitten discussed. But when stratified by age, 112 were less than 30 years old, 341 were less than 30, or greater than 30, but less than 40, and 249 were more than 40 years old. So all of these patients underwent FH-IHC testing. 287 had 2SC, because we acquired that later. It's a pretty new stain. And so of all of these, 102, 15% had FH loss, and 41 of 287, so a similar percentage had 2SC accumulation.
All of the FH loss and 2SC accumulation perfectly over.
They did not perfectly overlap. So I will show you where there is discordance. No, that's an excellent question. That's what we wanted to know. So you're on the right track. But if we're just looking at age as a variable here, we saw that when stratified by age, FH loss was seen in 18 of 112, so that's 16% of women less than 30, 84 of 590, so that's 14% of patients over 30, and 49 out of 453, so 11% that were less than 40 years old. And so that's 21% that are over 40 years old. So there's a wide distribution of just FH loss among all of these tumors for age. So when we actually got germline FH testing data back, only 33 of the 102 patients with FH-IHC loss elected to undergo germline testing. So of which, of those 33, 15, so that's like 45%, showed a pathogenic variant. And of these 15, 6, that's 40% were less than 30 years old. 9 were more than 30 years old, 60% more than 30 years old. And 14, so 93% were greater or equal to or less than 40 years old. And only 7% was more than 40. So there's most, yes, are less than, there's a clear age where these, where HLRCC tumors present themselves. They don't seem to present after certain age. So both 2FH and 2SC IHC appeared specific in the uterus. So we saw among tumors that are not leiomyomas, we didn't see any abnormal FH or 2SC staining. So that's things like leiomyosarcomas, picomas, IMTs, fibromas, stumps, endometrial stromal sarcomas. So here's the data on concordance. So we had 98% concordance between FH and 2SC. So great. Looks like there is 8 patients that have discordance between FH and 2SC. But so great. There's 8 patients. Let's look at the germline data. And this is very depressing and a little infuriating. None of those patients elected to have germline mutation testing. So we don't know what's exactly going on here in germline. So nonetheless, it appears that we might have detected 2 patients with 2SC that were not detected with FH, but we can't confirm that. Secondly, one tumor seems to have FH loss and no 2SC staining. So it's completely unclear what's going on with that tumor. And 5 have intact FH and equivocal 2SC. And most of these tumors do have morphologic findings of fumarate hydratase deficiency, but not all of them do. So this prospective study, it's the largest one to date, it does demonstrate that FH deficient uterine leiomyomas, they occur across a wide age range. They're morphologically distinct. They are preferentially associated with germline mutations in younger women. So we can cautiously conclude that if age is to be considered a factor in HLRCC screening of uterine leiomyomas, a threshold of 40 rather than 30, which is in a lot of the literature, might be most appropriate, provided at least some features of FH deficient morphology are present, because in our cohort, 60% of women with HLRCC would be missed if we were just not to screen them because they were older than 30, compared to 7% missed if we were to screen at 40. So this is still a work in progress. There's still a lot to do. So we want to acquire the missing genomic data where possible. We want to better quantitate 2SC positivity. We have equivocal staining for many of those. So we can do studies that are similar to those mentioned before to maybe have better determination of if that's actually positive. But there's additional variables that we can look at for better risk stratification. So tumor size, like I've mentioned a lot, multiple uterine tumors, specific types of morphology, adding other clinical features like cutaneous leiomyomas. And then another thing to ask ourselves is just why aren't more FH deficient uterine leiomyoma patients getting germline testing? So are they all just declining it? Is there a reason for that? Is it not getting through? And secondly, have we detected an FH deficient RCC in any patient who either has been getting screening, or did we like, I'm sure there's data in this hospital of FH deficient RCCs. Well, actually, we could probably tell if they occurred in patients who declined screening. So that would be interesting to know, but I don't know the answers to that. Yeah, longer, exactly. We'll find out in 20 years. Thank you very much. Thank you, Dr. Longacre, Dr. Sengoy, Ashley Munstrud, Dr. Fulkins, Rachel Hoden, who's genetic counselor, and Dr. Howat Yang, Dr. Kong, Dr. Barry Holson, Xiaoming, and all the residence fellows that have been ordering 2SC and FH on a lot of tumors, maybe not completely understanding what's going on here. So, this is going on since 2019. So, I'm just inheriting a lot of this. So a lot of other people have done a lot of this work, not just me. So this is my dog, Otis. And this is the real Krebs cycle. So thanks. Any questions?
The cutaneous, whatever the leiomyomas and the RCC, they presumably have the same pathogenesis, but one seems kind of stays benign, more or less. The other one is aggressive, overtly aggressive for the size of the tumor. Do they have additional mutations in the RCCs that would explain this difference in the prognosis?
Yeah. So the question is, are there additional mutations in renal cell tumors that explain the difference in prognosis? And I regrettably don't know that for sure. I really don't know. I'm sure someone in the audience probably knows, but I think about that often, and I also think about why do these tumors? FH is presumably it's ubiquitous in every cell. Why do these tumors only occur in smooth muscle of certain sites and the kidney? But I think that's just an ongoing mystery of molecular oncology. Same thing with like KRAS. I don't know, who knows if we'll ever figure that out, but it is very strange.
Any questions? No questions coming through.
That's really a lot of fun. Thank you.
Oh, thanks. Wonderful. Okay. All right.
I guess we could clap again. We can.
Thanks. All right.